Hello everyone, this is 20 MCQ. So in the stem of MCQ, 1 day old newborn has the dribbling after feeds. So mother is saying after giving the feeds, newborn is having dribbling or drooling from the mouth. He has respiratory distress in examination and froze at the mouth. X-ray is here. What is the diagnosis? So according to this history, dribbling after feeds and frothing at the mouth with the respiratory distress. Its history is very characteristic for the tracheoesophageal fistula. So whenever such history is there or admitted newborn is having frothing from the mouth, you should suspect tracheoesophageal fistula. Now see in this X-ray, this is the curl of the nasogastric feeding tube in the proximal part of the esophagus. It suggests that newborn is having proximal esophageal atresia, and with the changes of pneumonia and respiratory distress means fistula is also there between the distal part of the esophagus and trachea. Now see the option. First is tetralogy of Fallot, in which the history will suggest the cyanosis and generally not present in the newborn period except when the pulmonary atresia is there. B option is the correct option as I explained. In RDS, newborn will be preterm. At the time of birth will have the respiratory distress, or X-ray will show the either reticulogranular or air bronchogram or whiteout lung field. So this is not here, and history is also not suggesting the RDS. So this is the wrong option. Now the fourth option is congenital diaphragmatic hernia, in which X-ray will show the intestinal loop will be visible in the lung fields and abdomen is white out. It is not present in this X-ray, and in history part in CDH, newborn will have the at the time of birth gasping respiration or distress, and abdomen will be scaphoid. So right answer for this MCQ is tracheoesophageal fistula. So in the history part, whenever they are mentioning that newborn is having respiratory distress and changes of pneumonia can be present in the X-ray and excessive secretions from the mouth and drooling after feeds, then you should suspect that this is tracheoesophageal fistula. Here in this X-ray, you can see this is a nasogastric feeding tube which is curled over here. So this is characteristic radiological finding, and this history is characteristic of tracheoesophageal fistula. Now the types of tracheoesophageal fistula, there are 5 types A, B, C, D, E, and type C is the most common type. In type A, isolated esophageal atresia present, no fistula will be there. It is the second common type in 8% cases. Type B, where the proximal fistula with the distal atresia present, it is hardly present in 1% cases. And type C, where the proximal atresia with distal fistula, it is present in 85% cases. So because of proximal atresia, whatever feeds will be given to the baby in first 1 day of life will be drooled out. And because of distal fistula, whatever secretions are present in the esophagus will be through the fistula, go into the respiratory tract, and newborn will develop the aspiration pneumonia and respiratory distress. Sometimes double fistula with intervening atresia can be present. It is also very rare, hardly in 1% cases. Type A, B, C, D present in newborn period within 1 or 2 days of life. While the type E, where no atresia will be there, only isolated fistula, H type. So fistula between the esophagus and trachea present. So newborn can take the feed. Feed will go into the stomach and baby will digest also, but some amount of feed will also go into the respiratory tract. So baby will develop the frequent aspiration, and because of this, repeated recurrent pneumonia will develop, and recurrent pneumonia will lead to the respiratory distress and recurrent admissions. So this is generally diagnosed in infancy, not immediately after the birth in newborn period. This is present in 4% cases. So this is all about this MCQ. Thank you so much.